Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Welcome to the American Heart Association's Airway Management video. Airway management is one of the key interventions in the BLS and ACLS surveys. How you manage the airway depends on your training, abilities, and scope of practice. The optimal method of managing the airway will vary based on provider experience, EMS or healthcare system characteristics, and the patient's condition. The skills you will practice in this section of the course are essential to complete the ACLS case scenarios and testing. We'll review and practice effective bag mask ventilation in both single rescuer and two rescuer scenarios. We'll review the steps in responding to a respiratory arrest and the recommended use of waveform capnography to monitor and confirm the placement of an endotracheal tube. Before we get into the specific airway skills, let's review the recommended ventilation rate for cardiac arrest patients. Ventilations and compressions are important for patients with prolonged ventricular fibrillation, or VF, cardiac arrest, and for all patients with other presenting rhythms. But in the first few minutes of a VF cardiac arrest, rescue breaths are not as important as chest compressions. That's because the blood oxygen content remains adequate for the first several minutes after the onset of VF, regardless of whether the patient receives assisted ventilation. As the arrest persists, replenishing oxygen and eliminating excess carbon dioxide becomes more important. This is also true for cases involving drowning or other instances where hypoxia is the likely cause of the cardiac arrest. The American Heart Association recommends that during BLS, healthcare providers deliver 2 ventilations after every 30 compressions. Providers should not interrupt chest compressions for longer than 10 seconds to deliver these breaths. After inserting an advanced airway, providers should deliver 1 breath every 6 to 8 seconds, or 8 to 10 breaths a minute, while chest compressions continue uninterrupted. If a patient is in respiratory arrest and has a pulse but is not breathing, give 1 breath every 5 to 6 seconds, or 10 to 12 breaths per minute. After 2 minutes, reassess the pulse. For arrest patients, tidal volume should be approximately 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Providers should avoid administering tidal volumes that are too large or providing excessive ventilation. Not only can this cause gastric inflation and the resulting complications, but excessive ventilation increases intrathoracic pressure, decreases venous return to the heart, and lowers cardiac output and the patient's chance of survival. The skills you learn in this section of the course are critical to patient survival rates, especially in persistent cardiac arrest situations. Let's begin with basic airway skills. The first 2 steps in any airway management response involve opening and clearing the airway. First, open the airway using a head tilt, chin lift. Placing 1 hand on the forehead and 1 hand on the chin, push with your palm to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is safest on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. However, if the jaw thrust does not open the airway, use the head tilt, chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Here, suctioning may be necessary to remove secretions or foreign material from the mouth and base of the tongue. Use a large bore, non-kinking suction tube and a large suction catheter with a semi-rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider an airway adjunct to maintain patency. There are 2 main types of airway adjuncts. the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious or semi-conscious patients who still have a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. Here's how to choose the correct size OPA. When the flange is at the lips of the patient, the tip of the airway should be at the angle of the jaw. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. One method involves inserting the OPA with the tip pointing to the hard palate. Rotate the device 180 degrees until the tip touches the posterior pharyngeal wall past the uvula. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. If the device is inserted incorrectly or is too small, the OPA can push the tongue against the posterior wall of the pharynx, actually closing the airway. The OPA also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. Only healthcare providers trained in the proper use of an OPA should attempt its insertion into unresponsive patients. The nasopharyngeal airway, or NPA, is a soft, curved hollow tube that can be inserted through the nostril to facilitate ventilation. To choose the correct size NPA, place the flange of the device at the nostril, and the tip should just reach to the tragus of the ear. To insert an NPA, point the tip of the device away from the maxillary bone. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilations. If you feel an obstruction during insertion, gently withdraw the airway a centimeter or so, rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head trauma. With a known basal skull fracture, an oral airway is preferred. The NPA can be inserted in patients who are awake or who have a cough or gag reflex. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds.